Life enters an entirely new chapter after having an issue with your heart. And we're going to rejoin our guest, Kelly, as she talks about life after having a spontaneous coronary artery dissection. Thank you for joining us for this episode of Talking Health in the 406, where we're one community under the big sky. I'm your host, Jennifer Van Sickle, longtime healthcare worker turned health educator.
This isn't a joke. This wasn't a dream that you didn't wake up from. This is your life. And I wish in hindsight I could have said that I just, bounced right back, but it took a while. And when I finally did read about the discharge paperwork that she wrote me, the Mayo Clinic had a bunch of information, and they had a Facebook group of folks that have this condition that I kind of started to join. I was immediately welcomed into the group, and I learned the most from being in that group and subsequently reaching out to Mayo Clinic. And what they said is that about 10 years ago, SCAD, as they call it, which stands for Spontaneous Coronary Artery Dissection, was largely unheard of and commonly misdiagnosed. It currently is misdiagnosed frequently. And about 90% of patients that have SCAD are women, and it mainly occurs in women between the ages of 30 to 50 years of age. And unfortunately, of those women, the higher occurrence in the postpartum phase. About 40% of women have had a baby, and they're recovering from that. And so some early research into that, obviously there's a connection, a hormonal connection there. And the sad thing for those women is the heart damage and the effect of the tear tends to be much greater. It does occur in men. The men that do have this happen, they find that they were recently exerting themselves very heavily. Maybe they had run a marathon or done some very heavy lifting. But so those are the demographics. And present day, they don't, researchers don't really know, but there's obviously trends, and they're studying that. For myself, the most shocking part of all this was the gender disparities. When I looked into American Heart Association, the research showed that women are 50% more likely to be misdiagnosed during a heart attack. Women are underrepresented in cardiac research and clinical trials, even though heart disease is the U.S. leading killer of both men and women. And women are underrepresented in cardiac rehab. So for myself, that was a big part of my recovery mentally as well, was attending cardiac rehab. And it was just letting myself be able to trust that I could get back to doing things that I love. I could get back to taking a hike. And granted, it was going to be a long road because I had to let this artery heal itself.
So, Kelly, before this, when you left the hospital, had they said, keep your heart rate below this, or keep your blood pressure below this, or what?
So it's a great question. It was vague. It was vague because, there's just not a lot of research. And so the cardiologist's main discharge for me was, because I had this cardiac catheterization, no lifting on that arm, because that was really critical, the right arm that it went into for like a week. And then ongoing, the physical activity would be definitely limited as you see how I heal. And that was the really devastating part when I did the research of this. And she did tell me that when I was in the hospital, there is a risk of recurrence. And again, without knowing causation or having a lot of research, they don't really know when, how, or why that would happen. So in the early days, that was the main focus, is making sure that artery heals. And there was a general understanding of anywhere from 3 to 6 months, because that's just kind of how an artery would heal. But they don't know, that you could have a complication. And folks that were stented, which I wasn't, if a stent was placed, they would have more contraindications for lifting, and they would be on more blood thinners. The cardiologist told me that I would be on a blood thinner, but she said it's kind of an area that they just don't have any data showing that the blood thinner is necessary. And so as a cardiologist, she said her guidance was to give me the blood thinner and to put me on beta blockers just because that's kind of a standard of care.
Throw everything they can and hope something sticks.
Absolutely. Yeah. But it wouldn't necessarily increase the healing process. But so she did tell me they've given an estimated percentage of about 20% risk of recurrence. And again, that can happen anytime in your lifetime. And that would be where they look at, keeping like a lower heart rate and limiting extreme exertion. But it's a generalization. So you kind of work with yourself on that. And for me, that's where the cardiac rehab really helped me establish those. I did get chest pains in the healing period and kind of heart palpitations and felt the tiredness. And what I've learned since then is those are all common things that anyone who's had a heart attack experience. When your heart's healing, they said you do get palpitations. I've been lucky. I don't have any ongoing chest pain, but a lot of folks that have had this happen to them will get of an unknown cause. They don't know why, but they get chest pains. And they can take like something for the chest pain. They're assuming it's associated with SCAD because the person never had it before the SCAD, but I haven't experienced that. And because my cardiac rehab experience went so well for me, I've been able to go back to exercising. However, unfortunately for some folks, they, for one, maybe their anxiety has kicked in, but also they had potentially more serious heart damage and they've been advised not to. Or they had a repeat SCAD and then they've been advised to. So a generalization I was given to answer your question was to try not to have my heart rate go about 130. I wear a Fitbit, and to definitely, not overexert myself. So that would mean exercising. Yeah. Exercising to the point that you're like, high intensity workout. They call them like HIIT workouts, or in the event that you're doing something and a cardiologist, use an example in Montana, your snowmobile gets stuck in something and you're, vigorously trying to get out of something. Those are things that I have to stop and think that this is not the first 37 years of my life. And I can't do that, if you're caught that adrenaline moment. But I have been lucky. And I say that because as this Facebook group, that was really pivotal in my recovery. And I've networked with so many folks. That isn't the case for everyone. And so I think that's a good message because you can look at someone and think they look completely normal. They look completely healthy. Maybe you heard they had something in their health history, but they are having a lot more struggles with this and their recovery wasn't really linear and they've had a lot of setbacks in their life. Being put on the beta blocker, I'd mentioned my blood pressure was always really low my entire life. It lowered my blood pressure so significantly, I fainted a couple of times. And that landed me back in the ER just, within the 3 days of being home, not knowing was it a repeat SCAD? And then it was just found that I'm on the lowest dose of a beta blocker, essentially because I have really low blood pressure.
And so what is cardiac rehab? What does it look like?
So cardiac rehab is a fantastic program. And I was so lucky to have access to it in the town that I live. Unfortunately, there's folks in rural areas that don't have a cardiac rehab. Maybe their hospital is too small. They just don't have funding for it. But essentially, you're going to be doing, after a cardiac event, you're going to start getting back into doing physical activity. But because of having, damage to your heart muscle, you need to be monitored. So what that looks like is going to be individualized. And you're going to work with typically an RN who runs a cardiac rehab and then an exercise physiologist that is trained to read EKG monitoring. So you're going to be hooked up to a Holter monitor and you're going to do simple things like walk on a treadmill. Maybe it's a recombinant bike. Maybe if you feel up to it, you can do a slow jog. You're going to try to maybe lift some light weights. You're going to try to put a little stress on your heart and gradually do it in a safe, controlled environment. And it's twofold. unfortunate thing with heart damage is the heart muscle doesn't repair itself, but we want to see what pumping action you have. And they measure that with what's called your ejection fraction. By doing exercise, you can improve that ejection fraction. So we want to see that increase. And then also there's a mental health component too, because if you've had a cardiac issue, you've had lifestyle changes, you've had health problems.
Yeah.
So
we're walking around knowing 20% chance of reoccurrence.
Exactly.
Talk about something to carry.
Exactly. And even what we call like the traditional heart attack patient. And that's where, I wanted to do this podcast because that's kind of where the health disparity piece comes in. A traditional heart attack, a patient in America is an older man with, that comes into an ER clenching his chest. But any cardiologist, anyone who works in cardiac rehab, anyone who studies this will tell you that heart attack symptoms present differently in women. And it's not just men that have heart attacks. So part of that cardiac rehab too is increasing the person's ability to kind of just get back to a normal life and not feeling limited always. But men need that too. So, they've had, maybe it's a second heart attack or something, and depression is a common symptom to follow that lifestyle change. So that's what the cardiac rehab is for. It's kind of looking at what you can do going forward. Some people too might need that push. So for me, I was, not that typical patient. I wanted to get back to exercising. So they're kind of doing the opposite. They're kind of saying, unfortunately, we got to slow you down and let it heal. But that's what their job is. And that's what they do an excellent job of, is meeting the patient where they're at. And it's that secondary level of care. So the cardiologist is going to do what they can, whether it's a bypass, whether it's a stent, whatever they do in an OR, and they're going to do something pharmacological. Typically, you're going to be on a beta blocker or a blood thinner. But then how you recover in your life and how you improve that ejection fraction is the third piece, and that comes with cardiac rehab. And unfortunately, folks were, during COVID, a lot of our cardiac rehabs were closed. So a lot of our patients were doing it telehealth. And there was some early success with that. And we're kind of looking to that in the future with Apple Watches and how we can get telemetry to do it at home and how to reduce barriers so that if you live where you don't have a cardiac rehab, or you live in Montana where you're in a snowstorm and it's hard to get there, we can help get people moving safely. I'm just a huge proponent of cardiac rehab. And as someone who lives with this condition now, that's kind of, and I network with people from all over the world in the Facebook group I'm at. That's kind of where we're a broken record, but we're always encouraging folks to get to cardiac rehab. And it's highly underutilized. And I did want to say too, the Million Hearts Initiative, the US Million Hearts Initiative, they're trying to have a goal of 70%, I believe it was, I could be incorrect on that, of cardiac rehab participation, because the research shows that it's dose specific, that you're less likely to have another heart attack based on how frequently you attend cardiac rehab. So a general guideline, I think, is about Medicare and most insurances will pay for about 30 sessions. But for various reasons, folks might not be able to attend it. But however many sessions you can attend has a correlated risk to a reduced future heart attack. So we recognize that it's underutilized in this country, and particularly for someone like me who had no prior health conditions, it really is accredited to the quality of life I have today. And I also wanted to thank Mayo Clinic Research, because it was two female cardiologists who are leading U.S. research group on SCAD, and they have a research study going on I'm a participant of it, that is growing, and they network with some folks in the UK and Australia, I believe. But they were, the research was brought up by two women who had this condition, I believe in about 2012, and were just kind of perplexed by the lack of research, and kind of just like, they were discharged from the hospital and you have this rare condition, and they were kind of like, there needs to be more research. And it's Dr. Sharon Hayes and Dr. Marisa Tweet, and I'm a patient of Dr. Marisa Tweet at Mayo Clinic, and they heard these women out, and they kind of branched off and have started their own center at Mayo Clinic on SCAD research. So most of the data that I have been given as someone who had this in 2021 and going forward is really accredited to them and the women that reached out to them.
And so do you go to Mayo Clinic now for like a yearly checkup, or what does your Mayo Clinic?
Telehealth. Yes.
Telehealth.
And,
okay.
Yep. And that was a silver lining due to COVID. My insurance was able to cover that, the telehealth piece. And the good news was I had all the care necessary where I lived. And the main indicator that they look at to be part of the research study is the angiogram. Because again, the CT scans don't catch that arterial tear. So that's kind of, if somebody might be misdiagnosed with it, and to be part of the research study, they want to see that angiogram.
Which that would have happened in the cath lab. When
Exactly.
You went in and they put the wire in your radial artery. And
so it was a pretty simple research agenda. I just, gave them my information, and they kind of have a in perpetuity to a bidirectional referral. So if I was to have any cardiac test or that I have done outside of Mayo Clinic, will be transferred to Mayo Clinic so they can continue to research and study those health outcomes. And then the goal would to be to get some sort of clinical trial with a medication, because again, the beta blocker is kind of just that they give most folks with SCAD isn't specific to this condition. The beta blocker is just a generalized kind of heart medication. And they want to kind of research and hopefully get something more specific to having the arterial tear, and obviously also know what causes it. Potentially they won't be able to prevent it, but again, they can look at medications that could hopefully prevent it more.
Is there do they think there's like a genetic component or anything like that?
That's a great question. And they told me in the hospital they don't think so, because siblings they don't find really have it, so, which is interesting. But they look at kind of with the new age of 23andMe and your genetic profiles. The latest research they found is there is and I might be using the term incorrectly, so I apologize, but a genetic profile of folks that have this. So in other words, that you can have the genetic profile and not have a SCAD, but those that have the SCAD have this. And one of the really early interesting findings they had, and again, it kind of goes back to, you're so healthy, gosh, you're not a heart attack person. They said that they found these people have almost no plaque in their arteries. And they said it was an interesting finding that it's almost like a protective factor against having plaques is folks that have these genetic conditions that could predispose you to a SCAD. So it was just kind of an interesting finding when they put the data together in these research studies, because they found that that no one that has this, almost no one is having any sort of plaques in their arteries. So they're kind of studying that more, like what is the genetic predispositions. There are some rare instances where siblings have had it. And I also need to mention too, there's a condition called FMD, which I was screened for, and I was found negative for it. And it's just another one of these things they don't know enough about, but they do find a correlation to it. And sometimes they call it pearl string arteries. It commonly occurs in women, and they think it happens as you age. So like you wouldn't necessarily be born with it, but something in the aging process changes the arteriopathy, and you're more likely to have this.
And what does FMD stand for? Do you know? Or
fibromuscular dysplasia. And it's a unfortunate condition. My heart really goes out. Again, I haven't really definitively been ruled out for it, but it would increase your recurrence rate for having this again. And my understanding is it's not exclusive to an artery. So you can get it in your carotid arteries. You can get it in your kidneys. And for those folks too, that general kind of what does your day-to-day look like is much more restricted, because you have this artery that is more likely to, in blunt terms, break or pop again. I don't think it can be surgically fixed, because it would kind of just be in your body somewhere. So how they check that too, Mayo Clinic screened me. It requires additional screenings like a high-level CT to actually view the arteries. And then they have found a few other unknown, I should say, like genetic and rare conditions that correlate to SCAD. But in general, the term SCAD stands for spontaneous coronary artery dissection. And so that's kind of why they characterize what I have as that, because it's spontaneous and it's in an unknown cause. And as I said, they did know that there is a correlation to pregnancy, and they're very much studying a hormonal relation, which of course doesn't answer how it happens in men. But so their common thought that they've told me is it would be multifactorial. So something happened which caused the inner lining of the artery to kind of spasm and tear. And that tearing of it caused blood to pool up and occlude the artery.
To block it off, basically.
Correct.
Okay.
Yes. And so in the postpartum phase, there's a mechanism that causes that most likely to happen with postpartum women. In men, they think, something exertion, you lifted really heavy, you pulled something heavy, and that mechanism caused the artery to tear. But again, I don't fit any of those categories. Mine happened in my sleep, and there are folks that have that too. And another research correlation was with migraine headaches. And I have had migraine headaches, a history of that. And they said about 40% of folks have a history of migraine headaches. So again, that kind of correlates to something in an arteriopathy.
Wow. It's lucky you were, that you live in a large Montana town where you could have access to an emergency department that could monitor you all night, check your troponin levels.
Yeah.
Have cardiac rehab, which luckily a lot of our facilities in Montana can transfer people, recognize when it's getting a little bit more than they can handle.
Yeah.
And then for cardiac rehab, I imagine, there's huge cost savings. There's like almost $5,000 to $9,000 per year per person. And so, I feel like even if you don't have insurance, it's a worthwhile thing to try and get insurance, and then to try and get that service, I should say. And then Kelly, I know did you publish your experience on this, or have you tried to publish?
I didn't.
No?
So
Okay.
during this time frame, I researched a lot of cardiac rehab because, again, that was a sticking point for me, is the underrepresentation of women and kind of that health disparity. And you hear that when you, as a patient, I heard it, right? And it was an irony for me because in my background, I study public health and I'm aware of health disparities and I research them. But this was my experience as a patient. When I would talk to the RNs, and they say it's very common, women present differently and they get misdiagnosed more frequently. When I was initially in the ER, that's a common one. Or are you just having an anxiety attack? And we don't know how to respond to that. Well, maybe, I don't know. I have chest pain. I said, I've never had an anxiety attack, but why do you go to that, right?
Right.
And women have more challenges completing cardiac rehab. It just seems like because they're caretakers, right? And I only had a couple other gals when I was in the cardiac rehab program, but statistically it followed in the state in Montana and then nationwide too, that there's fewer women that participate. And whether they're, we don't really know whether they were under-referred or whether they just didn't get the message that it's highly important. And then there is the insurance factor too. So most folks who have heart attacks are at an older age and would be covered by Medicare, and Medicare definitely covers it. Medicaid does, but there are definitely private insurances that don't. And of course, as you alluded to, folks that don't have insurance, and that is a deterrent to it. Mm-hmm. Just with all the research that, is behind this, I would definitely encourage someone to reach out to a hospital foundation, to talk with someone. If they can't afford it, just some way. Most hospitals do have something, and anyone who answers the phone in a cardiac rehab will try to do something that works with you.
Yeah, very worthwhile. And so how are you doing carrying around this statistic and everything? How do you think of that all the time in your day-to-day life?
You would want to think that you don't. And that's kind of where it was kind of two things. Am I going to put this in my rear view and kind of just have it be this glip and, people have weird things that happen and move on? Unfortunately, I would say I can't because of that risk of reoccurrence and because of my own research and knowing that there's so much more that we need to do. I need to continue to advocate for it. and be part of these research studies. Because again, if my own people, if you'd call it, that have this condition didn't advocate and reach out, particularly to Mayo Clinic, I wouldn't potentially be where I'm at today. So I kind of feel and I wouldn't call it a sisterhood because we have wonderful men in that too, but there's an alliance of folks that we need to advocate for it. But I would say too that I'm lucky, and I want to make that clear. And I did have excellent medical care, and I was very lucky to have the family that I have. And so again, there's folks that have, other conditions that make their day-to-day life more restrictive, and folks that don't have insurance, as you said, that live in we have many health disparities in Montana and don't have access to a cardiac rehab. Or there still is much more that needs to be done in the first responder and medical community. It was a big success. Again, these two doctors that I alluded to, Sharon Hayes and Marisa Tweet, they said in their board exams for cardiology, it just like a couple years ago became a question on something about SCAD. So it still is, it's a well-meaning doctor, of course, but it still is commonly misdiagnosed. I've heard horrible stories of people being accused of using illicit drugs. And you can't point a finger because there's a ton of rare conditions in the world and someone can't know everything. But there is a health disparity that follows this because it's well documented that, a woman can even experience just kind of like a light pain. And I've told people that too. It wasn't the worst pain in my life. I've had worse pain. So it could have easily been, I could have easily been discharged that night and just been told to continue to take antacids. And same as, in a man that is very healthy and doing these marathons, you don't think, they had a lifestyle conditioned cardiac arrest. And so we just need to educate first responders and our medical community too, because we have the diagnostics, we have the troponins. And again, I had the indicators to show that, and I think we are getting there because, as I said, the advocacy and our research study database has been exponential. They said in about 2020, it was like less than 500 folks, way less than that actually, because it was just 2. And now I think in 2020, we're in like 5,000, 7,000 range, which is still low to get statistically significant results. But as we continue to promote it, and again, we get more of an accurate diagnosis, we'll increase that. And that's the other really unfortunate thing, is for folks to kind of think in their own medical history that grandma that, centuries ago, or when we say to, look at your health history with cardiac and they died suddenly and no one knows why, or, some sort of postpartum event. Historically, now we think, yes, these were likely a SCAD event. It was completely, unheard of. And we wouldn't have known until we had the diagnostic of an angiogram, which is relatively new too. I guess there's reason to be hopeful as my bottom line on that. And I'm thankful for the quality of life I have. But it isn't something that I can kind of just forget about again, because I don't like taking the beta blockers they give me for example, but it's just kind of one of those things that no cardiologist and no doctor wants to just say, just don't take them, because they do, they make you more tired. So just little things like that. But I also want to say that I've been very lucky in my own personal recovery. And, for the record, my own ejection fraction is basically back to what it was probably before. I never had one before a heart attack, but so my heart function is very well. So I just want to say, that isn't the story for everyone. And I always, that's kind of why I advocate and why I'm doing these podcasts, is because some folks once your ejection fraction gets that low, if they had a major SCAD, you really can't repair your heart to get back up to that. That's why we all do what we do. And I'm more than happy to be a part of the research study, whatever they want, and to continue to advocate for it and let people know the symptoms of postpartum, especially. That comes up when I'm in more urban areas, you'll meet like a nurse or a doctor that has had a patient like that, but in our rural areas where it doesn't happen much, it's still pretty unheard of.
I believe it. And I can see postpartum where they're saying, bleeding. They're worried more about, belly button down.
Right.
Essentially, is probably what the warning signs moms are getting, not
Right.
chest pain,
Right.
not anything like that.
And it's such a bizarre, anomalous thing because you're thinking, well, you're of childbearing age, so you're healthy in that sense, and you just had a baby.
Major
so
body
it's like
changes.
we've had you on monitoring and all that, so you're just kind of. But the good news with that too is the message is spreading. But we do need to, know that they need to be transferred to a high level of care because, again, to the cardiac arrest and, potentially a serious medical emergency to like a level 1 trauma is potential in those situations. So I do have just some kind of handouts for first responders because I do work with EMS now and potentially I don't think they do troponins in the field, but they do 12 leads and just kind of that awareness too, that you still can miss a heart attack or not necessarily a cardiac arrest, but a heart damage with a 12 lead easily.
And we can definitely have that on our website, Talking Health, in the 406.mt.gov, where everyone can download that. Absolutely.
And one thing I did want to mention, kind of in how you said, like, how am I today and sharing my story, you don't like to walk around. That's part of having a medical condition and just, how are you today? And it's always kind of hard sharing stuff like that. But since I do work with EMTs now, I shared this with a gal who works in a volunteer EMT agency in Montana. And she told me, that's really interesting because I got a call a while back and the woman was in her 30s and was completely healthy. Her 12 lead was normal, but her troponin was elevated. And they said we should take her into the ER. And she said that was really weird to me because we wouldn't normally transfer someone without, an abnormal 12 lead. So I think that, just little stories like that and broadening our scope on time-sensitive illness and injury, we've made a ton of progress on that. And Montana's had a lot of success with that. Mm-hmm. So.
Absolutely. I love it. Keep spreading the seeds and something will grow from it, Get more and more education and it's amazing. I mean, I get goosebumps thinking how the labs were saying something's wrong and you were saying something was wrong and your body just knew. You knew. And yeah, we have to pay attention to the patients for sure. Well, thank you, Kelly. We appreciate your time and we appreciate your story. It's amazing. So hopefully a bright, long SCAD, no reoccurrence future.
Thank you so much to Kelly for sharing her story and her journey through spontaneous coronary artery dissection, or SCAD, with us in this podcast. If you would like more information on SCAD or cardiac rehab or anything else you heard in this podcast, visit our website, talkinghealthin the406.mt.gov. And thank you for joining us for this episode of Talking Health in the 406, where we're one community under the big sky. Until next time, take care.